Hey everyone, and welcome back to Scrubs and Notes. I'm Raymond, and today we are tackling a topic that strikes fear into the hearts of medical students and clinicians alike: shock and sepsis. This isn't a single disease, it's a life-threatening state of acute circulatory failure. Mastering this topic means you'll be able to recognize and manage one of the most common emergencies on the wards. We'll break down the different types of shock, dive deep into the modern definitions of sepsis, and walk through the critical life-saving steps of management. So let's get into it. At its core, shock is a state of global tissue hypoxia. It's an imbalance where the supply of oxygen is insufficient to meet the demand of tissues. This cellular hypoxia forces cells to switch from efficient aerobic metabolism to inefficient anaerobic metabolism. This produces only 2 molecules of ATP per glucose molecule compared to 36, and generates large amounts of lactic acid, leading to a potentially fatal metabolic acidosis. If this energy deficit is not corrected, the cell's sodium-potassium pumps fail, leading to an influx of water, cellular edema, and eventually cell death. The progression of shock can be divided into 3 stages. That is pre-shock, which is the compensated stage, shock, which is the decompensated stage, and end organ dysfunction, which is the irreversible stage. In pre-shock, the body's compensatory mechanisms, such as the sympathetic nervous system and the renin-angiotensin-aldosterone system, kick in to maintain vital organ perfusion. You will see tachycardia and peripheral vasoconstriction, but the blood pressure may still be normal. In shock, the compensatory mechanisms fail. Hypertension becomes a key feature, along with signs of organ dysfunction like confusion and metabolic acidosis. And in end organ dysfunction, the damage is so severe that it cannot be reversed. This is characterized by profound hypotension, anuria, and coma leading to death. The key to managing shock is to rapidly identify its cause. Shock is classified into 4 main types based on the primary physiological problem. We have hypovolemic shock, which is the empty tank. The problem here is inadequate intravascular volume or preload. There is loss of fluid such as from hemorrhage or severe dehydration that leads to a reduced stroke volume and cardiac output. The body compensates by increasing systemic vascular resistance to try to maintain blood pressure. Patients are cold and clammy with tachycardia and hypotension. Their neck veins are collapsed and they are oliguric due to poor kidney perfusion. The most common causes are hemorrhage, that is from trauma or GI bleed, or non-hemorrhagic causes such as severe vomiting, diarrhea, burns, and diabetic ketoacidosis. Then cardiogenic shock, which represents the broken pump. The problem here is that the heart's pumping function fails. The heart muscle fails to contract effectively, leading to a massive drop in cardiac output. Fluid backs up into the lungs and venous circulation. Patients are cold and clammy with tachycardia and hypotension, but their neck veins are distended. You will hear crackles on auscultation due to pulmonary edema. The most common causes is a large myocardial infarction, but it can also be caused by arrhythmias or acute valvular regurgitation. Then distributive shock, which represents the leaky dilated pipes. Here the problem is massive vasodilation leading to a severe drop in systemic vascular resistance. The pipes, that is the vessels, they get too big for the volume inside. Widespread vasodilation and increased capillary permeability cause a relative hypovolemia as blood pools peripherally. The heart tries to compensate by increasing cardiac output, but it's not enough to overcome the low systemic venous return. These patients are initially warm and flushed with bounding pulses, a classic sign of warm shock. As shock progresses, they become cold and clammy. The most common cause is sepsis, but it can also be caused by anaphylaxis, neurogenic shock, or an adrenocrisis. Then lastly, obstructive shock, which represents a blocked pipe. Here the problem is a physical obstruction that impedes the heart's ability to fill or empty. A mechanical blockage prevents blood from reaching or leaving the heart, leading to a drop in cardiac output. The signs are similar to cardiogenic shock, that is cold, clammy skin, and hypotension. But the neck veins are typically distended, and the specific physical exam findings depend on the cause. The causes might include a massive pulmonary embolism, cardiac tamponade, or a tension pneumothorax. Now let's move on to sepsis and septic shock. Sepsis is the most common cause of distributive shock and a leading cause of death in hospitalized patients. Understanding its definition is crucial for modern practice. Now let us look at the evolution of its definition. There used to be the sepsis 2, or during the SARS era. This old definition relied on the presence of 2 or more systemic inflammatory response syndrome criteria, that is, fever or hypothermia, tachycardia, tachypnea, and a high or low white blood cell count, combined with a suspected infection. The major limitation was that such criteria are very non-specific and can be seen in many non-infectious conditions. Then there came sepsis 3 definition, which was in the dysregulated host response era. This is the current international consensus definition. It defines sepsis as a life-threatening organ dysfunction that is caused by a dysregulated host response to infection. This emphasizes that it's not the infection itself, but the body's overwhelming and pathologic response to it that causes the damage. Septic shock can be defined as a subset of sepsis in which profound circulatory and cellular abnormalities are high enough to substantially increase mortality. This is identified clinically by requiring vasopressors to maintain a mean arterial pressure above or equal to 65 mm of mercury and having a serum lactate level above 2 millimoles per liter, despite adequate fluid resuscitation. To quantify organ dysfunction and identify high-risk patients, we use scoring systems. There is the SOFA score. This assesses organ dysfunction across 6 systems: respiratory, coagulation, liver, cardiovascular, CNS, and renal. An acute increase in the total score by above or equal to 2 points from the patient's baseline is a marker of organ dysfunction. The Q-SOFA score, also known as the Quick SOFA, which is a simple bedside screening tool to quickly identify patients with suspected infection who are at a high risk of poor outcomes. It has 3 simple criteria, and a score of above or equal to 2 points at the bedside should trigger a high index of suspicion and an immediate response. That is hypotension, that is a systolic blood pressure of less than or equal to 100 millimeters of mercury, altered mental status, that is a Glasgow Coma scale of less than 15, and tachypnea, that is a respiratory rate of above or equal to 22 breaths per minute. The management of shock is centered around the concept of the golden hour. The sooner you recognize shock and begin resuscitation, the better the patient's chances of survival. Our approach is based on the Surviving Sepsis Campaign guidelines. The initial resuscitation bundle includes: start broad-spectrum IV antibiotics immediately, get a blood culture first, then start antibiotics within the first hour. The choice of antibiotics should cover the most likely pathogens for the suspected source of infection. Give fluid resuscitation for patients with hypotension or a lactate level above or equal to 4 millimoles per liter. Give a rapid initial bolus of balanced crystalloids like Ringer's lactate or normal saline. Apply vasopressors. If the patient remains hypotensive despite adequate fluid resuscitation, start vasopressors immediately to maintain a mean arterial pressure of above or equal to 65 millimeters of mercury. The first line is norepinephrine or noradrenaline, which is the vasopressor of choice. It is a potent vasoconstrictor with a good balance of alpha-1 and beta-1 effects. The second line is vasopressin or epinephrine that can be added if norepinephrine alone is not effective. An arterial line should be placed for continuous blood pressure monitoring if available. Other critical management steps include cess control. This is absolutely essential. You must identify and control the source of the infection. This can mean draining an abscess, debriding a necrotic wound, or removing an infected catheter. Adjunctive therapies include use of corticosteroids. Consider IV hydrocortisone for patients with refractory septic shock who are not responding to adequate fluid, and high-dose vasopressors. Provide supplemental oxygen to maintain the partial pressure of oxygen above 94%. Mechanical ventilation may be required for respiratory failure. And there you have it, a complete breakdown of the critical concepts of shock and sepsis. From understanding the cellular basis of shock to applying the modern sepsis 3 definitions and the life-saving Surviving Sepsis Campaign bundle. You now have the knowledge to recognize and respond to this medical emergency. If this video was helpful, please hit that like button, subscribe to Scrubs and Notes, and let me know in the comments what other topics you want us to cover. Thanks for watching, and I'll see you in the next video.